he is presenting the topic on psychiatric aspects of de-addiction and addiction. The problem is that still our community is not accepting alcoholism as a psychiatric disorder. ഞാൻ ആദ്യം ഇവിടെ വന്ന സമയത്ത് 20-25 വർഷം മുമ്പ് മദ്യപാനികളെ കൊണ്ടുവന്ന് സൈക്കാട്രിസ്റ്റിനെ കാണിച്ചാൽ അന്ന് സൈക്കാട്രിസ്റ്റ് എന്നല്ല പറയുന്നത്, വട്ടിന്റെ ഡോക്ടർ എന്നാണ് പറയുന്നത്. ഈ വട്ടിന്റെ ഡോക്ടറെ എന്തിനാ എന്നെ കൊണ്ട് കാണിച്ചു എന്നും പറഞ്ഞ് വാടിയിൽ നിന്ന് ഇറങ്ങിപ്പോയിട്ടുള്ള ആൾക്കാരുണ്ട്. റെഫറൻസ് എഴുതി കഴിഞ്ഞാൽ, മെഡിക്കൽ ഡോക്ടർ റെഫറൻസ് എഴുതി കഴിഞ്ഞാൽ വട്ടിന്റെ ഡോക്ടർ എന്നെ വന്ന് കണ്ടു എന്നും പറഞ്ഞ് ട്രീറ്റ്മെന്റ് റിഫ്യൂസ് ചെയ്ത ആൾക്കാരുണ്ട്. അപ്പൊ ആ സാഹചര്യത്തിൽ നിന്ന് ഇപ്പോഴേ നമ്മളിത് സൈക്കാട്രിക് സ്പെഷ്യാലിറ്റിയാണ്. സുസോഫ്രീനിയ പോലോ അതല്ലെങ്കിൽ മൂഡ് ഡിസോർഡർ പോലോ കാർഡിയാക് ഇൽനെസ് പോലോ പാർക്കിൻസോണിസം പോലോ ദിസ് ഇൽനെസ് ഓഫ് ദി ബ്രെയിൻ. Now in last 2 decades, after the invention of the new eras of brain, we found that there is a definite reason for addiction. There is a definite biological basis for addiction. ഇതിന്റെ വേറൊരു വലിയ ഭീഷണി നിലനിൽക്കുന്നത് കൗൺസിലിങ്ങിലാണ്. ഈ കൗൺസിലിങ് പെൻസിലിൻ പോലെ റിയാക്ഷൻ ഉള്ള ഒരു സാധനമാണ്. പെൻസിലിൻ സെൻസിറ്റീവ് ആയിട്ടുള്ള ആൾക്ക് പെൻസിലിൻ കൊടുത്താൽ ആ ആളുടെ റിയാക്ഷൻ ഉണ്ടായി ചത്തുപോകുമെന്ന് പറയുന്ന പോലെ തന്നെ കൗൺസിലിംഗ് അറിയാൻ മേലാത്തൊരു കൗൺസിലിംഗ് ചെയ്താൽ സെയിം റിസൾട്ട് തന്നെ ഉണ്ടാകുന്നത്. ഉത്കണ്ഠയായിട്ട് നമ്മുടെ അടുക്ക് വന്നില്ല, ചെറിയ മദ്യപാനമായിട്ട് നമ്മുടെ അടുക്ക് വന്ന് കൗൺസിലിംഗ് കഴിഞ്ഞവൻ ആത്മഹത്യ ചെയ്യുന്ന കണ്ടീഷൻ ആകരുത്. അതുകൊണ്ട് ദയവായിട്ട് നിങ്ങൾ ഈ വർക്ക്ഷോപ്പ് അറ്റൻഡ് ചെയ്യുന്നതോടെ എനിക്കുള്ള അപേക്ഷ, കൗൺസിലിംഗ് പഠിച്ചിട്ട് മാത്രമേ ആ കസേര കയറി ഇരിക്കാവൂ. വളരെ ഗഹനമായി പഠിക്കേണ്ട ഒരു വിഷയമാണ് കൗൺസിലിംഗ്. അപ്പോൾ സൈക്കാട്രിക് ആസ്പെക്ട്സ് ഐഡന്റിഫൈ ചെയ്ത് എപ്പോഴാണ് ഈ പേഷ്യന്റിന് സൈക്കാട്രിക് റെഫറൻസ് കൊടുക്കേണ്ടതെന്നുള്ള ഓരോ കൗൺസിലേഴ്സും മനസ്സിലാക്കണം. ഡോക്ടർ റോയ് ഇവിടെ പറഞ്ഞൊരു കേസിന്റെ കാര്യം പറഞ്ഞു, ഡെത്ത് ഉണ്ടായ ഡി-അഡിക്ഷൻ സെന്ററിൽ. ഇതൊരു ഇന്ന് വളരെ ഗൗരവമായ ഒരു പ്രശ്നമാണ്. ദ കമ്മ്യൂണിറ്റി വിൽ റിയാക്ട് ടു ദാറ്റ്. സോ കൺസിഡറിങ് യുവർ ഓൺ സേഫ്റ്റി ആസ് വെൽ ആസ് ഇൻസ്റ്റിറ്റ്യൂഷണൽ സേഫ്റ്റി, യു ഷുഡ് ബി ഏബിൾ ടു അണ്ടർസ്റ്റാൻഡ് and able to identify the patient. When should be the patient referred to a psychiatrist? And another thing is that always the de-addiction treatment should be done under the supervision of a psychiatrist. Then only we can identify the complications. The delirium tremens, more than 30% is the mortality rate. So in that aspect, Varghese will highlight you in the details. I am quite sure that you will be enriched with the new information shared with you by Dr. Varghese.
Thank you, Dr. V.K. Radhakrishnan, especially for introducing me as a young person. Special thanks to Dr. Radhakrishnan. I should also thank Dr. Shahul Amin for giving me this opportunity to start this workshop on the psychosocial issues in alcoholism. In fact, the topic, psychiatric aspects of alcoholism. The whole day is devoted to psychiatric aspects of alcoholism. We have very eminent faculty from renowned places like NIMANS, KMC Manipal, and we have non-medical professionals from different very renowned places. So my job is just to introduce the topic, which in fact all of this are going to be covered by the subsequent speakers. I was just wondering how I am going to put across this topic to an audience which is very heterogeneous. I understand that psychiatrists are there, postgraduates in psychiatric nursing are there, psychiatric social MSW students are there. So there might be some problems in communicating to a very different group of people. But in fact, that is the essence of management of alcoholism. So it is something which should be dealt with by so many professionals from different areas. So my presentation will be a little bit technical. We will, to begin with, once again to emphasize the problem, which has been brought up very beautifully in the keynote address. And of course, our chief guest also made a mention of that problem, that alcoholism should no longer be considered as a moral problem. It should be considered as a very unique problem with biologic, especially genetic, and of course psychosocial signatures. I'll be briefly touching upon the neurobiology of alcohol addiction, and very important, the concept of secondary alcoholism. A overview with regard to the terms which we are going to use. There should be a uniform language among the professionals. The World Health Organization has brought up ICD-10 and the American Psychiatric Association, the DSM. The terms used in these two different classification systems, especially with regard to the use of harmful use and abuse, what is meant by dependence, and finally, what are the alcohol-induced psychiatric disorders and what are the related comorbid disorders. So these topics will be briefly covered. Alcoholism, in fact, in one sense, it's a brain disease. The reward systems in the brain determine whether one person is going to become addicted to it. In the keynote address that was brought out as the vulnerability factor, you and me remaining not addicted to alcohol by and large to a great extent is dependent on how your brain is programmed. If your brain is programmed in such a way so that you are more likely or you are more vulnerable to become dependent on alcohol, you are at a very high risk. Somebody else may be having a brain programming or a brain wiring which places them at a lower risk. But we do not know. The current state of technology does not permit us to know in the general population who is going to or who has the highest vulnerability. Of course, we can make some inferences from the family history or some other from the historical, from the history. You may not be able to make certain predictions, but we do not have a foolproof method how your brain is wired. So some of the very important track is the particular neurotransmitter which is called dopamine. Dopamine is it's a chemical in the brain which gives us the hedonic experience, which means the pleasurable experience. So each person will have a different kind of wiring in this particular area. What is marked NA is the nucleus accumbens, which is a very important part of the emotional brain, the part of the brain which controls the emotional experiences and the emotional expressions. And this connection of dopamine in the nucleus accumbens is believed to be one of the very important determinants whether a person is going to become addict. So these pathways are called the reward pathways. The pleasure or the reward which a person derives from any behavior, let it be taking alcohol or engaging in a behavior like watching TV or let it be anything. So anything which may produce a rewarding experience in the brain is likely to be continued. I am not going to explain this very complex neuronal pathways in the brain, but this is just to highlight the fact that the addiction behavior, not only alcohol addiction, all addiction behavior, they are deeply rooted inside the very complex brain structures. These are some of the brain areas, and this is something which shows the important connections. This is a much simpler picture. We can see the nucleus accumbens, which is connected to very, very important areas of the human brain. And apart from this structural aspect of the or structural relationship of alcoholism, there are certain chemical determinants also. A number of chemical agents, which are generally referred to as the neurotransmitters, are involved in are determinants of addiction behavior. Of course, the dopamine, the opiate system. Opium is something which we get addicted to, but there are certain chemicals in the body which are called the internal opiate system, otherwise called the endogenous opiate system or the endorphins. So this opiate system is something which again gives you certain pleasurable or relaxing effects. This gamma aminobutyric acid, another chemical which is abbreviated as GABA, glutamate, serotonin, adenosine, corticotrophin releasing factors, neuropeptide Y. The list is not complete, but these are the important chemicals which are the researchers have found that these chemicals are very crucial in determining the addictive behavior. And some of the medications, there are so many. There is one session which is done by an eminent person on the pharmacological treatment of addiction. So many of the pharmacological treatment of addiction is based on the manipulation of these neurochemicals. So this is something which we have to educate to the patient and their family when a particular medication is prescribed. So that is not a simple sedative or tranquilizer, but this medication is going to manipulate certain aberrant chemical systems in the brain. So we should be equipped with this knowledge to give this health education information to the patient and their family. The positive pleasurable effects are mainly derived from the effect of dopamine, opiate peptides, serotonin and GABA. So here you can see a reduced dopaminergic function will lead to an unpleasant emotional state, which you can call it dysphoria, and reduced function of opiate system will lead to pain, and serotonin again, a dysregulation of serotonin may lead to again an unpleasant emotional state like depression or anxiety, and the gamma aminobutyric acid that will lead to symptoms like anxiety, panic, etc. So this background information we can utilize in educating the patient as well as their family that alcoholism is not a moral problem. It is something, definitely it has something to do with the brain circuit abnormalities. So we can see in the central part of the brain there is something which you can call as the reptilian brain or the primitive brain, otherwise technically called the limbic system. The primitive brain is responsible for pleasure-seeking behavior, and in fact our thinking, our actions or behavior is determined by the thinking brain, which is called the prefrontal cortex. So there is a bidirectional relationship between the emotional brain and the thinking brain. Even though a person intellectually admits that alcoholism is dangerous for him, Dr. Roy sir was describing the case of the famous medical professional, a great teacher in medicine. He was knowing, his prefrontal cortex was telling him taking alcohol is going to precipitate further episodes of hematemesis. So it is very dangerous to his life. But at the same time, the emotional brain or the primitive reptilian brain is making him crave for alcohol. This is not a very, of course I admit that this is a very simple way of looking at a very complex problem like alcoholism. But at least to our general population, we should be able to give this kind of message that alcoholism is primarily determined by certain biological vulnerabilities, certain genetic factors. I didn't touch the genetic factors because I'm afraid that we will go astray too much. And of course these brain mechanisms are primarily involved in making a person addicted to alcohol. Now I'll briefly touch upon the concept of secondary alcoholism. Even though the classification systems never mention about secondary alcoholism as such, it's a very useful concept which we can practice in the day-to-day clinical service. So when a person comes with alcohol abuse or alcohol dependence, in a proportion of these cases, alcoholism is a symptom of a primary psychiatric disorder. It is very, very crucial to understand that alcoholism could be a symptom. It could be secondary, at least in a proportion of the people who come for treatment. And most common problems are sometimes alcohol reduces the symptom of a pre-existing psychiatric disorder. Depressive disorders, anxiety disorders are very prevalent in the society. 10% is the prevalence rate for depression. If you take anxiety disorder, it may be up to 20%. So at any point of time in the general population, on an average, 20 to 25% of the people are having depressive disorders and anxiety disorders. So this is a big number. Most of the time, they are not properly identified and recognized as depressive disorder or anxiety disorder. So these patients may accidentally find out that alcohol very effectively relieves their depression and symptoms like social phobia. You know, social phobia, it's a very, very difficult situation. It's a very embarrassing situation. A person is unable to mingle in social gatherings. So alcohol is a very effective social lubricant. It's a relaxing agent, but the problem is that the effects are only temporary and the person may be beginning his journey down the lane to the dependence. So undiagnosed anxiety disorders like social phobia or panic disorder. Panic disorder is another very important anxiety disorder which often is misdiagnosed as a cardiac problem or a medical problem. So many people, it's not a rare problems. Depressive disorders and anxiety disorders are common problems, and the person may find it alcohol as a relieving agent. You may find long queues of women in general medical OPD. The same on the male side, the queue is very short, but in the beverage corporation, you can see a long queue of males. I'm sure that most of the people who are standing in the, at least a good number of people who are standing in the queue, they are having depressive disorders, anxiety disorders. They are trying to find out a treatment to relieve these very unpleasant emotional states. Again, alcoholism may be a characteristic of the illness as such. For example, in bipolar disorder is a basic psychiatric problem which is characterized by impulsivity. A person is unable to make a very controlled judgment. So he is impulsive. There can be problems with his judgment. Again, there is mood instability. All these basic features of bipolar disorder makes him prone to take alcohol. Schizophrenia is another condition. Antisocial personality disorder is another condition. So these are all basically psychiatric disorders, which alcoholism presents as a symptom of the psychiatric disorders. And finally, sometimes some of the medications can produce certain unpleasant side effects. It is not a very common cause. It may be a relatively rare problem, but the last one, alcohol may temporarily relieve certain symptoms like very disgusting symptoms like akathisia. Akathisia means it's a side effect, a rare side effect to certain medications where the patient becomes restless, and if you do not identify that it is akathisia, the person may opt for alcoholism, alcohol which may again relieve this akathisia and sleep problems. So this is the concept of secondary alcoholism. So the essential point, the take-home point is that whenever we see a patient with alcohol addiction or any other substance dependence, we should think in terms of, is there an underlying primary psychiatric disorder like a bipolar disorder, schizophrenia, a social phobia, a depressive disorder, or a panic disorder. So that is extremely useful. If you are not identifying the primary psychiatric disorder underlying the alcoholism, the symptomatic alcoholism, so the person is bound to relapse. The person will definitely go in for a relapse. So identifying and treating the primary psychiatric problem is of utmost importance. I will just enumerate the number of conditions given in ICD-10. ICD-10 is the International Classification of Disorders, which is proposed by the World Health Organization. World Health Organization, there is an alpha numerical coding for all health problems. The F, the chapter starting with the alphabet F is coding for all mental and behavioral disorders, and F10, 1, 1, 1, 2, etc. till 19 is related to the category of alcohol or other addiction related disorders. So you might come across case sheets or discharge cards where these codings are given. I would advise it is always get familiarized with the updated classification of World Health Organization. World Health Organization is coming up with the ICD-11. ICD-11, which is very likely to get published in maybe in 2012 or sometimes it may be in 2013, I don't know. So we are generally following this ICD-10 categories. First of course is the acute intoxication. I am not going to describe it in detail. I would just clarify some of the confusion, use of terms, certain confusions with regard to the use of terms. So I will touch upon harmful use and dependence syndrome. Withdrawal state, alcohol withdrawal state may or may not be associated with delirium. Alcohol-related psychotic disorders, alcohol-induced amnestic disorders, and residual and late onset disorders. These are the broad categories given by the International Classification of Disorders. Whereas the Diagnostic and Statistical Manual, the 4th revision is available now, and it is by the American Psychiatric Association. If you read the literature, rather than ICD, most of the literature on addiction and alcoholism, they follow this Diagnostic and Statistical Manual. The alcohol intoxication is the same. Alcohol dependence, withdrawal delirium, delirium tremens. But there is a little bit of difference between ICD and DSM with regard to the use of terms like harmful use and abuse. That I will highlight in the next slide. And you see a number of conditions described by DSM as induced by alcohol. Alcohol-induced cognitive disorders. There are 2 types. Alcohol-induced psychotic disorders, alcohol-induced mood disorders, anxiety disorders, sleep disorders, and sexual disorders. So these are the broad categories which are enumerated in the Diagnostic and Statistical Manual of the American Psychiatric Association. I thought I will highlight on the difference between the ICD usage of harmful use and the DSM use of abuse, because it appears that there is a little confusion among the professionals when they use the term abuse and dependence. This clarity will be there if you stick to the definitions given by ICD and DSM, which is not very difficult. A harmful use is the term used by the ICD. ICD-10 does not use the term abuse. Abuse is used by DSM. ICD-10, harmful use refers to a pattern of use of alcohol leading to damage to health. So damage to health is the main problem. So a use of repetitive or recurrent use of alcohol leading to damage to health. So damage to health, health means physical health or mental health. So damage to physical health or mental health, if it is really present, then only we can call it alcohol, a harmful use of alcohol. If there is a potential risk of developing a medical problem or a psychiatric problem, we are not supposed to use the term harmful use. So when there is a proven or a definite harmful use, damage to either physical or mental health, this is the term harmful use is employed. So just because somebody disapproves a person's habit of taking alcohol, just because the spouse is critical of taking alcohol, we cannot say that it is harmful use, because the definition is very much limited. It is focused only to damage to physical health or mental health. So this is the ICD usage. But if you look at the DSM-4, the comparative or the comparable term used by DSM is the abuse. So abuse, the definition is a little more wide, a wider definition, which says abuse means a maladaptive pattern of use of alcohol which produce a distress or impairment in one of the 4. A list of 4 conditions are given. If there is a distress or impairment in any of these areas, leading to distress or impairment, you call it an abuse. A failure to fulfill the role obligation. If a parent, if a father is neglecting his family, his role obligation is not respected, it is not carried out, then it is 1 out of 4. That qualifies for abuse. And second thing, using alcohol in a physically hazardous situation. A medical professional going to the operation theater intoxicated. So this is a harmful physically hazardous situation. Or driving. Related legal problems, a person landing up in legal difficulties because of with use of alcohol, and continued use despite recurrent social problems, even if the person experiencing problems with regard to his job or family or the society. So at least 1 out of these 4, if they are present in the previous year. So that person qualifies for the description of abuse. So I hope the difference is clear. The terms harmful use by ICD and abuse by DSM should be clearly, the difference should be clear. And again, but the confusion with regard to the use of abuse and harmful use is not there when you come to the dependent syndrome. It is almost the same, DSM and ICD. Of course, there are certain differences, but we need not worry about the nuances or the hair-splitting differences between the ICD-10 and the DSM-4 concept of dependent syndrome. So, by and large, generally, ICD and DSM is an agreement how to define a dependent syndrome. So, ICD says a strong desire. Dr. Roy was telling the overpowering desire to take alcohol, the strong desire, and ICD even goes to the extent of using the term compulsive, a compulsive use of taking alcohol. So that is a very important criteria. A person has difficulty with control, not only the quantity, but also a person fails to control initiating the alcohol or stopping after 2 drinks or 3 drinks. He may think that he may stop after 2 drinks or 30 ml or 60 ml. He is unable to do that. So control problems are the second criteria. Physiological withdrawal state. A physiological withdrawal state is, you are all familiar with that, the tremor and all the physical symptoms associated with withdrawal, and taking a medicine or taking an alcohol to relieve such symptoms is another important criteria. The fourth criteria is the evidence of tolerance. Tolerance, we know that the person is able to tolerate more quantities of alcohol. More quantity of alcohol is needed to produce the same or the desired effects of alcohol. So the person, usually in Malayalam, ആൾക്കാർ വന്ന് നമ്മുടെ അടുത്ത് പറയുന്നത് എൻ്റെ കപ്പാസിറ്റി കൂടി, എനിക്ക് ഭയങ്കര കപ്പാസിറ്റി. സോ they may boast that they have become tolerant of alcohol, but it's a very it's a red flag that the person is going to develop or is already on the path to develop dependence. And the progressive neglect of alternative pressure. Again, the keynote address mentioned the primacy of taking alcohol. A person gives importance to take. The whole life or the time schedule revolves around the taking of alcohol. And finally, something which is common to the definition of abuse and dependence is a persisting use despite evidence of harmful use and consequences. And out of this 7, if 3 or more are present in the previous year, the person qualifies for dependence. DSM-4 also, it is almost the same. Tolerance, withdrawal, larger amounts for longer period of time, unsuccessful efforts to cut down, time spent. So this is something which all of us know. I am just revising it. The essential message is that dependence, the ICD and DSM, there is not much of a difference between the concept in ICD and DSM. So we can use either, go by whichever is easier for us. We can go for that. They are very similar. Some of the differences, as I already mentioned, ICD uses the term compulsion, a compulsive desire to take alcohol, and DSM, with or without. Finally, after a person is diagnosed as having dependence, with or without physiological dependence, a person with physiological dependence and without physiological dependence. What are the characters which determine whether a person is physically dependent? One is withdrawal symptoms, other is tolerance. So presence of withdrawal symptoms and tolerance, if they are present, we can say the person is having alcohol dependence with physical symptoms. If they are absent, it is without physical symptoms. So this distinction is very important because alcohol dependence with physical symptom definitely indicates a more severe problem. And remember, it is interesting to note that only 3 out of the 7 symptoms are needed. So one need not have always physical dependence to diagnose alcohol dependence. Even if physical dependence is only 1 out of the 6 or 7 criteria laid out by ICD-10 or DSM. So even if physical dependence is not there, a person may qualify for alcohol dependent syndrome. And we can see what is being termed as the diagnostic orphan. Some patients neatly meet the criteria for harmful use. Another group may meet the quality for abuse, and a group of patients will meet the criteria for dependence. But what happens if there are only 1 feature of dependence or 2 features of dependence? The definition says, or the criteria say, if only 3 or more symptoms are present, dependence can be diagnosed. What about if the person is having two? So they are being described as the diagnostic orphans. And diagnostic orphans, of course, that does not mean they do not have a problem, and they do have a pattern, something which between abuse and dependence. And most of these patients may be nearer to abuse rather than a more severe problem like dependence. Again, this should be kept in mind. If you are strictly applying an ICD criteria or a DSM-4 criteria, there may be a group of people who do not neatly fit into this criteria. And there have been criticisms that it is the problem of using categories in psychiatric diagnosis. It should be more of dimensional rather than category. These are all nosological issues which I don't want to go into the detail. Another confusion is with regard to when will you say a person has got an induced psychotic disorder. In the DSM category, if you look at the psychiatric conditions produced by alcoholism, we have a number of conditions. Alcohol-induced amnestic disorder, alcohol-induced dementia, alcohol-induced mood disorder, alcohol-induced anxiety disorder, alcohol-induced psychotic disorder. But the same person, people with alcohol can have, as I already mentioned, in the case of secondary alcoholism, depression may be there even before they have initiated alcohol. Anxiety disorders may be there even before they have started alcohol. So there occurs a lot of confusion when a person with alcohol dependence do present with anxiety symptoms or depressive symptoms. Were they present even before the person started taking alcohol? Did he start taking alcohol just to relieve his anxiety symptoms or depressive symptoms? Or the depression you see, the anxieties you see, or the psychotic features we see in our consultation room, are they induced by alcohol? So this is a very difficult question, and I will try to give certain guidelines which may make things more clear. First, of course, we should need a syndrome, not the presence of certain symptoms, to make this diagnosis. In fact, majority of the patients, so most of the literature say, more than 80% of the people who present with alcoholism during the intoxication phase or during the immediate withdrawal period, they may have symptoms of anxiety or symptoms of depression. That will not qualify for a diagnosis for an induced disorder. A full syndrome of depression or a full syndrome of anxiety should be there to qualify for the diagnosis of an alcohol-induced anxiety disorder or a depressive disorder or whatever be the psychiatric condition which we have. So the presence of symptoms, if you are diagnosing anxiety disorder, depressive disorder just based on the presence of symptoms, you will be over-diagnosing. So in order to prevent this over-diagnosis, the criteria clearly says that a full syndrome should be present. And second thing, there should be non-clinical evidence that a particular substance is likely to produce a particular symptom. For example, in the case of alcohol, which is the topic of discussion today, alcohol is known to produce anxiety disorder. It is known to induce psychotic disorder. So that criteria will be satisfied by alcohol. So it should be the substance in question or the substance abused or on which the person is dependent should be, or should evidence should exist that it is capable of producing such a syndrome. And the third point is very, very important. The symptoms should not be, or the syndrome of anxiety or syndrome of depression or syndrome of psychosis should not be confined to the period of intoxication or withdrawal. During the period of intoxication or during the period of withdrawal, you may get a mix of so many symptoms. Anxiety symptoms, depressive symptoms, psychotic symptoms, etc., etc. So any symptom which is described in all classical textbooks of psychiatry may be present during the period of withdrawal. That will not qualify for a diagnosis of an induced disorder. And finally, if a particular syndrome, an anxiety syndrome or depressive syndrome or psychotic syndrome, whatever be it, if they recover within a month of stopping alcohol, that is likely to be an induced condition. If it is persisting beyond this 1 month period, 1 month is an arbitrary line drawn by experts. So it does not literally mean that with the end of 28 days or 38 days the diagnosis change. But this is somewhere we have to draw a line, and that is why an induced condition, alcohol-induced disorder usually disappears within a period of 1 month after the person stops alcohol. So that again should be borne in mind when we use the term induced disorder. And finally, this should result in functional impairment. There are certain exceptions. This rule, when you call something as an induced disorder, I said it is temporary, it is self-limiting, and it stops, or the person recovers after a period of 1 month. The two exceptions are cognitive disorders, amnestic disorders, amnesia and dementia. These are persisting conditions. Even beyond 1 month, even beyond 4 weeks, these cognitive symptoms may persist, and still we can diagnose an alcohol-induced amnestic disorder or alcohol-induced cognitive dementia. One of the commonest diagnostic confusions come here. An onset clearly predating the dependence or persisting beyond 4 weeks of abstinence. We are tempted to diagnose an induced condition because alcoholism is the most dramatic event in the patient's life, and the patient is brought for the treatment of alcoholism. But a careful consideration should be given. When did the problem start? If it was clearly antedating the dependence, and if it is persisting beyond the period of 4 weeks, we should not diagnose induced disorder. It may be a different or an independent diagnosis. So this is just to highlight the point which I already mentioned. So temporary symptoms can occur in most of the patients, almost 80% of the patients, and they may improve naturally. But of course, naturally means that does not mean no treatment is needed. The person has to be carefully followed out for a period of 4 weeks. 1 month follow-up should be very, very careful. And after a period of 1 month, 4 weeks, the person should be reassessed for the persistence of this problem. If that is there, definitive treatment should be given. Otherwise, the psychosocial methods of treatment, supportive treatments, and sometimes pharmacological, even pharmacological treatment may be needed. But the point is that if that is the case, a pharmacological treatment need not be continued beyond 4 weeks. This is something which has been suggested by authorities to clarify this confusion. When we take a history, establish a timeline. What exactly? The patient or the bystander may not be able to give a very clear history with regard to the onset or the course of the problem. But if you really spend time and try to get information from different sources, it is possible. So whatever time we spend on establishing a timeline may be very, very important to achieve a high level of diagnostic clarity. For example, the starting point, the age of establishment of dependence. So more than, we get a very clear history that the person started using alcohol by the time he was in the 11th standard or 12th standard. So that may not be. More than that, the timeline should be starting at the age of establishment of dependence. At what point of time in the person's life he has become dependent. That is more important than at what point of time the person has initiated taking alcohol. And second thing, in the timeline, we can indicate if there are periods of prolonged abstinence lasting several weeks or several months. Again, that should be noted on the timeline. And the period at which a major psychiatric syndrome like depression or anxiety or psychotic disorder has appeared. So if this timeline is drawn with a little bit of effort from our side, they may not be able to exactly tell you the which year or month. But when we take the history, if we can relate it to the major life events like the passing the 10th standard examination or getting engaged or going out for a job, etc. If these major life events can be marked, we can get a timeline. Here, in the red line on the left side, that may be the starting point. The person was, the black dotted line represents use. Or somewhere in the timeline, the person has for the first time developed dependence for a period of time. And in between, the black dots represent certain symptoms, but not a full-blown syndrome. But over here, at this point of time, the person has developed a full-blown syndrome, a syndrome of an anxiety disorder or a depressive disorder. So this will settle the issue whether a particular problem which we are meeting is a primary psychiatric problem or an independent psychiatric disorder like a depressive disorder or anxiety disorder. So in the first one, you can see from the description that it is the person has been taking a little bit of alcohol, but he developed a depressive episode, and after that he was abstaining for a long period of time, and this is an independent problem. It is unlikely to be induced. But here the person was taking alcohol, but the person developed the same kind of problem while he was taking alcohol, and that was persisting for a period of time. And in the second, the lower line, you can see the period of episodes, which is shown here by, you can see clear-cut episodes. So the second line mostly indicates an induced disorder, whereas in the previous one, it could be an independent. But this may not be, still it could be difficult, but at least we can make an attempt to know whether the person has got a primary psychiatric problem which is relatively independent of the alcoholism, or the psychiatric symptom like an anxiety disorder or depression is a part of, is an induced by it. And now I'm not going to make a mention of all the psychiatric disorders because it will not be possible to finish it in the time frame, but just a mention about cognitive disorders. Alcohol-induced cognitive disorders, there are mainly two types. One is the Varghese, the so-called Korsakoff syndrome. In many places I find the use of Korsakoff psychosis. Korsakoff psychosis is a misnomer. There is no psychosis here. The only problem is that the person is having a memory problem. The memory problem, and look at the figures, 30% recover with thiamine supplementation. But majority of them, more than two-thirds, half to two-thirds, will only have a partial recovery. So it is very, very important to prevent a Korsakoff's amnestic, a memory problem, a relatively permanent memory problem should not be allowed to get established. So all the professionals working in the with de-addiction make sure that the patient is receiving large doses of thiamine. Thiamine is a vitamin which is very much necessary for the functioning of neurons. So it is something which is involved with the glucose metabolism. Glucose is essential for the survival of neurons. So if the brain is deprived of this very important thiamine, vitamin thiamine, which for many reasons, for many medical reasons, the patients with alcohol dependence, they are having a thiamine deficiency. Most of them are having thiamine deficiency. So even if they do not manifest any clinical features of thiamine deficiency, very, very important point to administer large doses of thiamine in injectable forms, in parenteral forms, whatever be the case. The patient might have come with a other problem. So this simple measure of administering thiamine can prevent permanent memory problems. So that is the take-home message. Alcohol-induced anxiety disorder, as I said, majority of them will experience fear. I'll finish in 2-3 minutes. Okay. Chairperson is looking at the watch. It's a sign. So 80%, most of them experience anxiety symptoms, an intense fright. So one need not go for a specific treatment for all these conditions. But if it is persisting, we have to think in terms of an alcohol-induced anxiety disorder. If it is persisting beyond 4 weeks, and if it was not there before the development of dependence, so that could be an anxiety which is induced by alcohol. But here again, remember, once again reminding you that pre-existing conditions, a good number of patients, they have certain anxiety disorders like panic disorder, social phobia, or in our places it may not be very common, the post-traumatic stress disorder. If you look at the Western literature, there are a number of references to post-traumatic stress disorder. People who have been exposed to extraordinary trauma in their life, they may develop certain anxiety symptoms. So if such kind of symptoms predating should not be diagnosed. One is not supposed to use the term alcohol-induced condition, but at the same time they should be addressed in the treatment during the maintenance phase or the follow-up phase. Alcohol-induced mood disorder. Mood disorder can be of the depressive type or the bipolar type. Alcohol is known to induce mood disorder. Sometimes depression may predate. Majority will report depressive symptoms, but those who meet the criteria may be coming to only around 15%. The ICD use the term organic mood disorder. And the treatment of this depression again can wait till 4 weeks. The specific treatment can wait till 4 weeks. So we should not be too enthusiastic to start on antidepressants, but supportive measures can be given. The person should definitely be reassessed after 4 weeks for the persistence of depressive syndrome. And if it is persisting, a definitive treatment or a specific treatment for depression should be given. Alcohol-induced psychotic disorder, the figures given is 3%, but I am afraid whether it is slightly more, especially with regard to our population, our male population. Dr. V.K. Radhakrishnan is nodding his head in agreement. I am sure that this percentage may be more than, it may be something to do with our genetics. Our male population are prone to develop psychotic disorders, especially of the delusional disorder. I don't have the statistics, but the experience from the clinical practice shows that the incidence of delusional disorder, samshaya rogangal, it may be more with alcohol, it may be induced by alcohol. So it has got a lot of clinical implications. And finally, rather than the induced psychotic disorder, anxiety disorders, depressive disorders, psychosis, I mentioned, even these many psychiatric conditions listed here, bipolar disorders, schizophrenia, anxiety disorders, depressive disorders, it is anxiety is typed wrongly, depressive disorders, the bipolar disorders, depressive disorders, schizophrenia, anxiety disorders, two types of personality disorders. Two types of personality disorders are common, antisocial personality disorder and borderline personality. I don't know whether we come across so much borderline personality in our culture, but maybe in the Western countries and in the metros or with the changing social and cultural lifestyles and values, we may be coming across more number of borderline personality disorders with alcohol dependence. So this may be common. Finally, recently there has been some interest with regard to a relatively new finding that adults with alcohol dependence, at least some of them are having this particular problem called attention deficit hyperactivity disorder. ADHD, we all know that it is considered as a disorder of childhood, but it is known that at least 2/3 of ADHD may persist into adulthood. People who have difficulty in maintaining the attention, who are restless, who are impatient, who are impulsive in their decisions.
मैं शराबी नहीं, फिर कोई पिलाएगा तो मैं क्या करूं. വളരെ പ്രശസ്തമായ ഒരു ഗസലാണ്. അതിൻ്റെ അർത്ഥം എല്ലാവർക്കും അറിയാം ഞാനൊരു കുടിയനല്ലെന്ന്. പിന്നെ എന്നെ കുടിപ്പിച്ച ഞാൻ എന്ത് ചെയ്യും? ഈ കുടിപ്പിക്കുന്ന പ്രോസസ്സാണ് വർഗീസ് പറഞ്ഞ ബ്രെയിനിൻ്റെ 2 ഭാഗങ്ങൾ. അപ്പോൾ 2 ക്വസ്റ്റ്യൻസ്. എനിബഡി? So as you are very well understood all this.
Social worker, but not much background in medical, but more interest in the social aspect.
The wiring of the reward systems is only a vulnerability factor. That is not a causative factor. So that makes a person more vulnerable to develop an addiction process. So vulnerability does not mean the person will essentially develop it. There are of course social factors which society has become permissive and it has become socially acceptable. The age in which a vulnerable brain gets exposed to a substance like alcohol in very early life, these are all factors which capitalizes on this vulnerability.